Many a times you have situations where you have an obscuration of the fundus view and you have a no glow. Most common diagnosis people say is a vitreous hemorrhage, but actually it's not vitreous hemorrhage. It can be a mascarade syndrome where you can have vitritis or vitreous inflammation and you can have no glow. We have a distinguished speaker, Dr. Dhananjay Shukla, to talk about and clear your doubts about it.
Thank you, Avneendra. First of all, I thank Dr. H.K. Tiwari and Avneendra for allowing me to be a part of this symposium instruction course. So, my commission for the day is to talk about know-how of no glow that masquerades of vitreous hemorrhage. Actually, when you talk about masquerades, the masquerade is a term we typically use for the cases of uveitis. But there are some cases of masquerades, or there are some masquerades, some conditions which masquerade of vitreous hemorrhage as well. So some masquerades are common to uveitis and some are not. I'll here list only the most common conditions which look like vitreous hemorrhage. It can be an infection like endophthalmitis. It can be any of the ocular tumors. It can be a retinal detachment, a choroidal detachment, or a suprachoroidal hemorrhage. Now you may say that endophthalmitis is actually it's a no-brainer of a diagnosis. It's a painful eye with hypopyon, with a red eye, and it follows immediately after cataract surgery. But there are some cases which present late, like in late postoperative endophthalmitis, or you can have a case of trauma in which you may not be able to differentiate endophthalmitis from vitreous hemorrhage, and both may coexist in such a case. So one way to suspect endophthalmitis or vitreous hemorrhage is to look for the actual evidence for a globe puncture. So in our institute we see a lot of times a case referred as traumatic endophthalmitis, whereas the patient has actually suffered a blunt trauma, or there is no evidence of a obvious or covert perforation or puncture. In some cases of old vitreous hemorrhage, the organized or clotted vitreous hemorrhage looks like the exudates. In these cases, the history, the symptoms and ultrasound can be diagnostic. However, some of the signs can be deceptive. For example, hypopyon may not always be present in endophthalmitis, especially if the patient is treated with topical antibiotic and steroids, or the pain may be coexistent in a vitreous hemorrhage also because of trauma, or it might have been subsided again by the use of steroids in a case of endophthalmitis. In some of the cases like this, you can see that there is some retinal infiltrates, but unfortunately we are talking about the no glow differential diagnosis where these kind of findings are generally not visible. So the main diagnostic investigation in all these cases will be ultrasonography, V-scan ultrasound. Now in a clear-cut case it may be very obvious, but in some cases the doubt may remain forever. What you see below is a case where there are multiple membranes. So when you have several membranes overlapping each other and freely floating, that's one more suggestive of endophthalmitis. Also look for the RCS, the retina choroidal sclera complex. Especially the choroidal thickening, which will be a low reflective thickening as seen on the A scan, is typical of endophthalmitis. However, a warning is that in trauma, you can have an RCS thickening even in the case of vitreous hemorrhage. In a real-time setting position, when you have a clotted vitreous hemorrhage and it is looking like exudates of endophthalmitis, the reflectivity will be seen more in the lower part. It is suggestive of a vitreous hemorrhage, or if the reflectivity is uniform above and below, it is more suggestive of endophthalmitis. Remember also that a very fresh vitreous hemorrhage actually may have no echoes at all, because this ultrasound may pass freely through the fresh blood particles. When in doubt, endophthalmitis should be presumed rather than vitreous hemorrhage. In such cases, an intraocular antibiotic should be given. Now I come to a much more severe condition, the most common primary cancer of the eye, choroidal melanoma. Unfortunately, the stage at which choroidal melanoma is a differential diagnosis for no glow, the things are already out of hand. We know that Shields has told us that about 30% of the medium-sized melanomas metastasize and lead to death, and about half of the large melanomas do the same. So in a tumor which you are seeing in the lower picture, in this size of a tumor which can cause a low glow, actually the survival is less than 1 year in most patients. However, some cases may be small and may be associated with vitreous hemorrhage or vitritis, and that is where the role of the ophthalmologist becomes more important. Here the early diagnosis is critical, And in a clear media, of course, there is a 5-sign mnemonic called to find a small ocular melanoma given by Jerry and Carol Shields. I'll not go into it right now. It's not relevant to us. But you should remember it to diagnose a small melanoma. It's extremely important. Here, the tumor which we see as a differential of vitreous hemorrhage, the key to diagnosis is ultrasound, which shows an obvious tumor with low to medium internal reflectivity. Now here I want to highlight that it may not be always seen as a low internal reflectivity or acoustic hollowing, and some tumors some melanomas are seen like this with a uniform reflectivity. Mushroom shade may not be always present, especially in the early stage of melanoma. However, in all the cases the tumor can be seen. So the treatment is enucleation for the large tumors and brachytherapy for the medium tumors, while the small ones can be observed. Now let me come to the most common differential diagnosis for masquerades themselves. That is, now primary intraocular lymphoma, which is more precisely called primary vitreoretinal lymphoma, because there is not a uveal lymphoma from which it must be differentiated, is actually a large cell lymphoma of the B cell variety of non-Hodgkin's type. It's also called a reticulum cell sarcoma. It is frequently associated with CNS lymphoma, which is seen in 60 to 90% of the cases. However, the reticulum cell sarcoma may be the first presenting sign. Now it's important to differentiate because it is fatal if it is not treated. Now what are the most classical findings? The most classical findings are simply vitreous floaters, which is a representation of the white cell infiltration of the vitreous. Now white cells can also be seen in and under the retina, which may be confused with retinitis or choroiditis, as you see in the picture below. The diagnosis is extremely difficult, and the most important signs to look at is in any case of floaters. Now remember that in most cases of floaters, the patient just complains of floaters and not really a drop in vision. So the patient is complaining of floaters which are progressively increasing, which are bilateral and which are associated with actual drop in vision, should be looked for with an active suspicion of primary intraocular lymphoma. In some cases, remember that there may not be any systemic signs. The vitreous biopsy yields are frequently poor, and to confound the matters further, oral or topical steroids can be effective to some extent in reducing the floaters and confusing the picture further. So one should have an active suspicion and elicit a history of focal neurological deficits and mental changes in such cases of floaters. How do we increase the yield of the vitreous biopsy? We should use a low cut rate and gentle aspiration. Should place the specimen immediately on the eyes and hand carry it to the pathologist, whom we should notify in advance. These blast cells are actually 3 to 4 times larger than the normal lymphocytes, and they can be picked up by PCR, flow cytometry, by immunohistochemical markers, and sometimes even by checking the interleukins levels in the vitreous. The systemic neurological examination is a must whenever required, and it's a neurologist call to decide whether to order a CT, MRI, or analysis of CSF. A complete blood count is what we should order. ELISA for HIV should be done whenever we suspect, depending on the patient's build and history, because with the increase in the incidence of HIV, the incidence of primary intraocular lymphoma has also increased. Now let me come to a common diagnosis, but still which is sometimes mistaken as retinal detachment. Now again, it's very obvious when the media are clear whether it's a retinal detachment or which is causing the no glow or the vitreous hemorrhage. But remember, it can coexist with vitreous hemorrhage, as Dr. Tinku Bali has just mentioned, and one such incidence is trauma. Now RAPD is generally the way to differentiate a retinal detachment which is present, for example, behind a cataract. A patient with cataract may present with a retinal detachment or vitreous hemorrhage, and one way to differentiate is RAPD. So it's a very simple test that we miss in the patient with total vitreous hemorrhage, with a total cataract, who comes because of trauma or at an early age. However, RAPD may present again in a traumatic episode because of traumatic optic neuropathy. So we should use an ultrasound to differentiate. It is generally differentiated very easily, but sometimes there may be problem of reflectivity, homogeneity, and mobility. For example, it is different to say which of these two membranes are retinal detachment and which is subtotal posterior vitreous detachment. By reducing the gain, we can generally make out, because the PVD generally almost disappears because of the low reflectivity, where the retina remains more or less undisturbed by the reduce in gain. The other features are the increased after movements in of the PVD, and also again, when they coexist, again you look at the lower part of the fundus, the PVD is seen more staining in the lower part than the upper part. Kissing choroidals are another sign of, evidence of no glow, and they are generally associated with the hypotony, which actually reveals the diagnosis as being a leaky wound or a bleb. Ultrasound is helpful as seen in the picture below, and it's diagnostic, but they can occur when in suprachoroidal hemorrhage when they cause a problem. Once we address the cause of hypotony, even kissing choroidals can be observed for up to 2 weeks. And that brings me to suprachoroidal hemorrhage. Again, the expulsive hemorrhage is seen intraoperatively is not a differential diagnosis. But unfortunately, especially after trabeculectomy, it can occur even late after the surgery, after several weeks. So, and it can also present with the vitreous hemorrhage after penetrating trauma. So here the ultrasound is diagnostic. Again, this is showing a kissing choroidal with hemorrhage rather than subretinal fluid under it. The default management is to wait for 7 to 14 days. We should not start draining or giving mannitol immediately in these patients. We have to see whether the macula is on or off, whether RD is present or absent, or whether the subretinal fluid is blood, and the blood, whether it is liquid or it is clotted. So this is how we differentiate subretinal blood from the subretinal fluid by ultrasound. To sum up, various ocular diseases mimic vitreous hemorrhage. Most of them are more severe and sometimes even fatal as compared to typical vitreous hemorrhage causing conditions. The trauma causes the most confusion is also cause overlap of the various conditions, and ultrasonography is the key to diagnosis. Thank you.